So tell me, because obviously, people here are listening, they know that you're a doctor. When it comes to going to care team visits, and I feel like people with diabetes might be jaded because a lot of us have not had a great experience over the years. Like I've had this almost 25 years. I can probably say I've had one or two providers in that whole time on the diabetes side that have been actually helpful, useful resources that I felt like actually supported me and, put the care in care team. So with that, what would you say? Like, welcome to the Your Diabetes Insider podcast, where we take all of the mysteries of blood sugar control, focusing on nutrition, exercise, and any of the other 40 plus factors that may impact your blood sugar. If you don't know me, my name is Ben Zeal. I'm a registered dietitian, certified diabetes educator, strength and conditioning coach, and I've lived myself with type 1 diabetes for over 20 years. And I am here to share everything that I have learned in both my personal and professional experience so you can live that incredible diabetes life. So get ready and let's dive right into today's episode. All right, welcome to this episode of the Your Diabetes Insider podcast. And I've got an awesome guest today and someone who's going to help you get a better experience the next time you see your care team. I've got Dr. Mike Devano. What's going on?
How's it going, man? Thanks for having me.
I'm so excited to talk with you about so many things related to diabetes care and just, getting the most out of your visits, because I feel like no one ever talks about it. But also, can we just shout out the fact that you are one of the first physicians that I've ever met who actually lifts and is good at it too. Can we just shout that out for a second?
Thanks, dude. I appreciate it.
I feel like, and again, you can correct me if I'm wrong here, but I feel like in my experience, it's hard to find, maybe you get a doctor occasionally who is able to be active and work out, but it just feels like in my experience, maybe I can count on one hand, maybe two hands in my entire life with diabetes, the number of healthcare providers I know of that train. So thank you for practicing what you preach.
Yeah, man. I totally agree. Not a lot of providers lift. And I think a part of it is we don't learn it in school, and we don't learn it, maybe not even just in school, but just as a part of life to begin with. Yeah.
Well, and I feel like too, with the more and more research coming out about, how much muscle impacts not just blood sugars, but just your life and improving bone, lifting, improving bone mineral density and all these different things. I feel like we go on and on about that, but out of the gate, just so people get to know you, right? Because they may be like, who is this guy? Tell us just a little bit about you, your background, and any connection to diabetes.
Yeah. So I am a third year in family medicine residency. I'm finishing up in June. I went to school. I'm a DO. So I went to school over in Lake Erie. Not the actual Erie campus because it was way too cold there. I went to the Florida one, I think we talked about it, over in Bradenton. So that was cool. Finishing up my third year of residency right now. So I'll be an attending soon. Really in exercise, really into powerlifting, obviously, and kind of trying to teach patients the way of exercise. Obviously not competitive powerlifting. Not everyone needs to be someone that lifts that much. But I think the baseline for exercise for both patients and providers is pretty low. So kind of fighting that front, as well as fighting a lot of the nutritional mumbo jumbo that we have on Instagram and not evidence-based things is kind of where I find myself fitting in, as well as doing some primary care stuff. And the diabetes, it is the bread and butter of family medicine. So I feel more than comfortable dealing with, 95% of my type 2 diabetics. Type 2 diabetics. Type 1 diabetics get, I admittedly a little bit harder because they need a lot more TLC and there's a lot more nuance to it that after following you on Instagram, I realized. So having an endocrine doctor on board is super helpful, but that's my experience with diabetics. And also just learning about how does exercise now fit into these different pathologies? As much as I love exercise for the layperson, how does it fit for sugars for a type 2, type 1 diabetic? How does it fit for someone with cardiac disease or other weird, I had a patient with Ehlers-Danlos syndrome that I was dealing with exercise. So they have really stretchy skin and really elastic tendons and ligaments. So how does exercise look for that person? Yeah, that's kind of my experience.
Well, it's interesting that last patient that you alluded to, because there's been a few people that have come through our practice that have type 1 and I can never say it, Ehlers-Danlos.
Ehlers-Danlos.
We've had a couple of people that have gone through with both. And I'm again, all of the different autoimmune conditions and just how I feel like with diabetes, especially on the type 1 side, it feels like a buy one, get one free. You get something and you're getting something else. It's just a matter of which one do you luck out in terms of getting.
Yeah, 100%.
And so tell me, because obviously, people here are listening, they know that you're a doctor. when it comes to going to care team visits, and I feel like people with diabetes might be jaded because a lot of us have not had a great experience over the years. Like I've had this almost 25 years. I can probably say I've had one or two providers in that whole time on the diabetes side that have been actually helpful, useful resources that I felt like actually supported me and, put the care in care team. So with that, what would you say, like for someone who's interviewing a new doctor, they want to get in with a new doctor, what is an important thing that they should be looking out for so they can maximize their time and make sure that they know it's a good fit?
Yeah. So like green flags, I got a few points here. Interrupt me if I get too rambling because sometimes it can be like that.
Of course.
So I think the first thing is you need to find a doctor who like truly listens, right? Like I think there's this statistic in some sort of published paper where a physician will listen to a doctor. It was either like for 7 seconds or 9 seconds before they interrupt and then just start yapping about what they want to do for the patient, which I think that's pretty bad.
Yeah.
I think from the patient's perspective, they're the ones living with the symptoms and have a lot on their chest to like talk about. Some related to the condition, some related to like their feelings about their symptoms and things like that, which I think they're all super important. But a doctor who's checked out, like mentally or is just focused on clicking around in the chart, isn't giving you your full attention and doesn't let you finish a thought or like finish what you're saying without chiming in their thoughts and like a treatment plan already. I think that's a green flag, someone who does listen to that. So that would be my first point. And like we're taught this in residency, right? Like to learn to not interrupt and things like that. But there are small kind of like, at least in my residency, we're taught like the nonverbal things, right? Like turn your chair towards them, as much as we are burdened with a lot of like the charting, it's nice to like write down what the patient is saying. But I think, just sitting and listening and like all eyes, all ears on the patient makes that like relationship a lot better. Although you lose some time on the back end, kind of catching up with documentation, like you build a much better relationship and the things that you would like to implement are a little bit more bought in on the patient side. So that's the first thing is the doctor who just listens.
And as we get to that, I want to make sure, because let's just say in this case, you're a patient, you're looking at it from the patient side, brand new doctor, they don't even know if the doctor listens. Like, is there any sort of resource that you know of? I feel like I've definitely searched a few doctors' names on Google before, and I've had, like the equivalent of rate my professor for doctor is health grades or whatever. Like, is there a resource where people could look up and say, hey, does this doctor listen, or is their bedside manner good?
Yeah, I think some of the reviews are good, like especially if they're overwhelmingly good, then you can probably trust that. But I think if someone's got like, take it like any like restaurant review, read the review sort of thing, and it's not about the food, if it's about the decor and how it like looked and things like that, it might not hold the biggest weight. But yeah, that's because I feel like reviews is like the loudest people are the ones that are like heard, and oftentimes it's a complaint. You might have a great doctor who doesn't pay any attention to the reviews, and they've got like 2.5 stars because they rub 1 or 2 patients off the wrong way, which is bound to happen, and they're stuck with that 2.5-star review. So yeah.
Well, and I have to ask that because I know a lot of times, even for me, like I've been looking, okay, if I'm a patient and I'm looking for a new endo, I'm hearing 6 months, 9 months, 12 months of a wait time before I can even get in. So if I'm that patient and I'm thinking about that, if I'm waiting that long, the last thing I want is to go into with a new doctor, go into a session and have this doctor not pay attention. Now I'm back at square one, having just wasted almost a year. So that I feel like is just so important to say, okay, is there a way of knowing, not if you call the office, of course, they're going to say, oh, the doctor's great. But, is there another potential way of finding out that you've seen from your experience on the inside?
Yeah, as you were talking, it just came to my mind, word of mouth referral. So I think like if a patient comes to me and is like, who's a good endo that you like? Who's a good podiatrist that you like? I have my go-to because patients love that doctor or I love that doctor, and I know like they treat me, they have the same green flags that I would want out of a doctor. And like, when I come to them with like referrals or questions, they don't tear me down. They're like, this is what I would do. This is, I'm happy to see them, happy to fit them in. Like those are the type of people that I would want my mom or my dad to see. Similarly, like if a patient asks who's a good endo, like you're going to that person, that sort of a thing. So word of mouth actually, I think is pretty useful. Ask your primary care provider who they send people. Yeah.
That's what I was about to say. It sounds like the primary care side of things, if you really just don't know, they may have, especially if you have a good relationship with them, they may have some good insight into someone who's good within your area. And then, obviously going from there, hoping you can get in sooner than 6 months. But again, if you have a good rapport, I think that's a big starting point.
Yeah. And I think it goes the other way too. Like, there's a classic, when you're in residency, those classic docs in the hospital where like, you're scared to give them a call and ask them about like to consult them, like whether it's cardiology, neurology, whoever it is, and like they just tear you down. I got good advice from like faculty where it's like, if they treat you that way and they, you have good clinical questions, just imagine how they treat patients, who are maybe less informed or just have general good questions and they tear them down. Do you want to refer your patients to them? So they're already like X'd out in your mind. You're probably not sending those patients to that provider.
Well, and so let's say, like you just mentioned, let's say you ask your PCP, they give you a great option, you call in, you get an appointment scheduled, you show up and they're giving you eye contact, they're listening, they're maybe taking some notes, but they're generally listening. What would that next green flag be to say, hey, this is a person that I should continue seeing that actually cares?
Yeah, I think it should always be like a collaborative teamwork approach. And I don't know if the way I do it is the best way or the right way, but it's, if you come to me with your symptoms and your complaints, I approach it like, I'm going to explain my thought process. This is what I'm worried about. This is what we should do. This is where the evidence base lies. These are kind of our options. What are your thoughts? And I always leave it at that. It's unless something, I think of it as this kind of yellow zone where unless something is like, no, like you're going to get hurt or you're going to die soon or you're going to do this or you're going to do that. Like I need you to be on this. If it's in that kind of like yellow zone, I try to approach it with a much more collaborative approach. And I think a lot of medicine has done. So yeah, if you've got, a plan that you want to instill in a patient or, start out, I think it should be a good back and forth collaborative teamwork approach. So that would be kind of the next step. It's like, what are your thoughts on all of this? Because I just gave you so much information about your symptoms and what I'm thinking of. You might be scared. You might be curious. Like, what are your thoughts? That sort of collaboration.
So it sounds like really keeping the door open. They listen, but then they say, hey, here's what I'm thinking for a treatment plan, but really involving you in that process as well, instead of just do this because I said so and I'm the doctor. So therefore you should do it.
Yeah. And I would hope medicine is kind of, I don't know if that's like the traditional older doc kind of vibe that is passed down. I think now in residency, we're learning a lot more from the patient's perspective. That's probably not the best approach to instill change, like behavioral change too, like as much as it is just not probably the right way to practice medicine, the right way of practicing medicine also like gets the patient to buy in as well. So, yeah.
Well, and I feel like it's just, there's a lot of people, like I will talk with people all the time and they'll say, my team doesn't listen, or my team is my way or the highway and that's it. And I'm like, what if you're in that situation? Like if you're the patient, are there certain questions that they should ask to try to reestablish the relationship or redefine it? Or are they kind of just, hey, that's how it is, the precedent's been set and they need to go elsewhere? Like what would you say as the provider in that situation if it's already off to a rocky start or you've been established for a couple of years and it just hasn't gone well?
Ask the question again. So like if that happens from the provider's perspective or
from the patient's perspective, let's just pretend I'm a patient and I've seen you for a couple of years. This is all hypothetical. And, the relationship's been kind of what we were describing that we didn't want, right? Like you're saying, hey, this is how it's going to be. This is what's got to happen. You're giving me hell because you don't love my lab results, et cetera. And I don't like that. And I know like my options are I can get another care team or I can stay as an established patient. And it might take 9 months to get a new care team. Is there a way from my perspective as the patient to reestablish that relationship and say, hey, like I want to advocate for myself. I want things to be a little differently, or is it too late or does it just depend on the provider?
I think it depends on the provider. Hopefully you have a good provider who is able to like check themselves, sit down and be like, all right, like the patient seems uncomfortable, doesn't, isn't bought in, wants to explore other avenues. Hopefully you have a provider who like takes that seriously. If they don't, despite you as a patient saying otherwise, then I think it is time to like find a new provider. But in the moment, I think at least what we're taught, like as providers, like when you're trying to pitch something that you're worried about or like a case that like you want someone to take a little bit more seriously, you voice the words like, I am concerned or I am worried about, or I am confused about, right? So like kind of taking ownership of that like feeling from the patient side, where it's like, I am concerned that if I do this will happen, right? Can you tell me more about that? Directing questions in that manner, at least a good provider will be like, oh, snap, like they're worried about something or their goal is not matching my goal or that sort of a thing. And even from the provider standpoint, I like to say, because oftentimes you have to meet patients where they're at, and what you think is right for them is not what they have in mind. So always at like a good provider will always ask as well, like, what is your goal, right? Is your goal maximizing your diabetes care? Is your goal trying to live as long as you can, as best as you can? Or is your goal like you just want to enjoy the last 3 years of life in the best way you can, just not in a hospital? And I think like if you approach it in that sense, you get a little bit more clarity as to why a patient is, feeling a certain way. So a good provider will say that, but also from the patient's perspective, taking ownership of that, like, I am concerned about something, or I want you to listen to my concern about this. That should put a stop to the provider in their decision making for a quick second.
Because some of them, I'm sure you can imagine, like some of the patients that I'll talk to or some of the people that will come to me will be like, hey, my doctor doesn't listen. My doctor doesn't care. They're useless for me. And I hate hearing that because I feel like it should be such a collaborative process. But to your point, I'm sure a lot of the providers inadvertently may be doing it to themselves to a degree, and they don't even realize they're doing it.
And I think it's like the dynamic between the patient and provider is also just very like, in a way, like it's this weird professional, maybe sterile environment, but like, don't forget about the human touch to it. Like if I can clearly see that I am not like vibing well with a patient, or there's something on their mind, I say, hey, like, it seems like you're very worried, or it seems like something is wrong, or what I'm saying isn't connecting well. Like, what can I do? So, I don't know if that's medicine, more so just like a family medicine touch or whatever it is. I think it can go the same way with the patient, right? Where it's like, hey, like what I'm trying to say, I don't think you're hearing right, or, I don't think you're addressing my concerns. Can you listen to what I have to say? Sort of a thing, right? So it goes both ways, and it's more like humanistic in that way, where it's like, I just want you to listen to what I have to say and what I'm concerned about. Can we address that? Yeah.
Well, and I would imagine from the patient side, if the doctor, then you're advocating like that and they're still ignoring it, then it's time to just peace out with somebody else, because they ain't going to change leopards ain't going to change their spots at that point, right?
Exactly. Yeah. And I think that goes for anything in any professional setting. If, whatever it is, it's like, all right, now this is, all right, I just got to go.
We're done here kind of thing, which is just wild. But so we've talked about the provider listening, being open to the feedback from the patient. This is an aside, but I am just curious. I know in the diabetes world, especially in the type 1 world, people tend to do a lot of their own research. They try to find resources, they try to dig into things, and they'll come to us with questions. I know they come to the providers with questions as well, especially on the doctor side. How do you approach someone who says, hey, I just found out, and I'm going to make all this up, but it's a clear example. I just dug into the carnivore diet and it looks like the best thing since the flush toilet. I'm going to do it. And let's just say it just does not align with any part of the treatment plan. How do you approach that? And how would a patient know if the doctor, actually is on their side, or, actually has their best interest?
That's a really good question. So like, is it something that the provider clearly knows isn't good, or like,
isn't good for that patient? Isn't good for that patient in that situation? And this is a curiosity thing. I'm also curious as a fellow healthcare provider, right? Like I'm curious because I know for what I would do, but the doctor side is a little bit different.
I think it goes to that like green zone, yellow zone, red zone thing. So I'll put carnivore diet maybe in that yellow to red zone. Maybe, like in this example, or it's clearly not good for the patient, just for the example's sake. Something like would be in the green zone is something like where they want to take a supplement that might not help them, but certainly won't hurt them. The green zone I approach, this is what I know about it, which I think is the first thing we should talk about, is like, if I don't know something, I am not, what's the word? Like, I won't lose any sleep saying that I don't know something. I don't know. I guess like I come at it from a place of like, I still need to learn. So like, after this visit, I'll go learn a little bit more about it. So that's the first thing, where it's like, if the provider doesn't know about something, like they should admittedly say it. Going back to like the carnivore diet, like example, I think, is it gonna knowingly hurt them? I think is.
Well, and that's the thing. Like if it's someone, like if they came to me and they're saying, I want to do carnivore, I think carnivore may work for certain people. I'm just trying to use it as a very extreme example of someone who did their own research and they're like, the carnivore diet's the best thing for me. I want to do this, but I want to run it by you first. And you're like, this could not be a worst possible idea for this person.
Or I'll take it twofold. One where it's like, they're definitely going to get hurt, versus one where they're not. So I do this a lot with my weight management patients and like weight loss patients, is like this idea of like the North Star, and like your goal being the one thing that you always measure your actions towards. So what is your goal with switching to the carnivore diet, right? Like, is it better blood sugar control? Is it to feel a certain way? Is it to lose a bunch of money buying meat products and fat products? Or, what is your ultimate goal? And once you instill a plan, you look back up to the sky and are you still walking towards the North Star, right? Your goal is better blood sugar improvement. Now that I'm 2 weeks into the carnivore diet, how is my blood sugar? How do I feel? Have I lost weight? Whatever your goal was, you always pin it to your ultimate goal. And if you're walking away from your North Star, then you know that it's not helping, right? So you can take that to anything that anyone wants to try with a lot of mumbo jumbo, non-evidence stuff, or even evidence-based things, right? Where it's like, I want you to be on this medication because I think you're going to be healthier for it, or let's try insulin, or let's try this plan for this insulin. Like, and the North Star is whatever goal that we set, are we closer towards that? I think pinning your actions to ultimately, are you closer to the goal, is probably how I would approach it. And then if it's going back to like, that if the carnivore diet wasn't going to hurt them, now taking the other side, if the carnivore diet, for this particular patient certainly will hurt them, I have to voice my, my recommendations against it. Like, hey, you're in this kind of red zone where I'm like, you shouldn't adopt this, sort of eating plan or protocol because XYZ. And that going back to the humanistic approach, where it's like, that is my ultimate like medical recommendation. I'm worried that this will hurt you. At the end of the day, it's always your decision. I have to document that, like, you're gonna agree with me or not agree with me, and ultimately it's your decision. But I have to voice that from a medical standpoint, I'm worried that you're going to get hurt, right? So,
well, and I think also just you even there going through that process from the doctor side, saying, hey, this is how I would go about it, but also being willing to pay that extra attention to detail, I think would go a million miles with most people anyway, because most people aren't. We joke in the diabetes world, right? You get your 10 minutes of glory. You wait, an hour and a half in the waiting room to get your 10 minutes of glory, to usually be told, fix this, here's your script, have fun, see you in 6 months, like, help it all. So that being said, feeling heard, I think just out of the gate would be huge. But what else would you say other green flags people should look out for, or should be, trying to find with their care team or assess their care team for, to know if they need a new one? What else would you say people should be looking to have?
Yeah, I think so. The last point that I have here is just like, the provider should have the heart of the teacher. My fiance and I were just recently in the house, like we were on the market to buy a new home. And so first time home buyers, we're out of the market now. It's crazy out there. I don't even want to get into that. But like, starting off as new first time home buyers, you like know nothing, right? And like, it's a big financial decision. You don't know which direction you're going to go, if that's going to be the right decision. So you trust your lender and you trust your real estate agent. And thankfully we had great ones that were just, they really took on the heart of a teacher. Like, this is what you should do. These are the things you should look out for. And this is how I would approach it, right? So that made me feel way more secure in like my decision, and that if my decision went south or north, like I'm okay with that because I had the most information at hand. So like, a provider that has the heart of the teacher really expresses or manifests itself in like how they approach the treatment plan, and going back to that collaboration and their thought process. So like, I think starting someone on a statin is one of the hardest things to do, because like like anti-cholesterol medication, because we know, elevated cholesterol can lead to down the line, which is what makes it so difficult to convince people to start on it, is increased risk of stroke, increased risk of heart attack, right? And those things don't knock on your door one day, and it's like, hey, now's your time, you're going to have a heart attack. It certainly builds up over 10, 20, 30 years. You add obesity and smoking into that, it makes it, a higher risk. But to get someone to realize that upfront, that like, hey, you're at a higher risk than someone otherwise. This is why you should be on a statin. These are my thoughts on it. This is why we think it's an important thing. And teaching and educating patients in that manner is super, super beneficial, because then from the patient's perspective, it's like, oh, I have a lot of information now, like to think about and to weigh out, right? Should I make this decision or not? If I don't, this is the repercussions. If I do, these are the repercussions. And ultimately that decision lays on me. So going back to that kind of example, is non-diabetics, I tell them, at least I use two kind of risk stratification. So any person with an LDL greater than 190, evidence-based shows that they should be on like a low dose, moderate dose statin to prevent their risk, or to lower their risk of heart attack and stroke. And then the other one is their ASCVD risk. So their atherosclerotic cardiovascular disease risk, a 10-year kind of risk stratification of if they're going to get a heart attack or stroke in 10 years. And I tell them your risk is based on your cholesterol, your age, your smoking status, your sex. You have a 7.5% or 10% chance of getting a heart attack or stroke in the next 10 years. Right. And like laying that out, like how is a patient supposed to know that? And how is a patient supposed to know that like that's what you're thinking and that's why you're pushing so hard for a statin, right? And if you tell them that, it's now they have more tools in their toolkit to make an informed decision. And I think ultimately that's what it is. You just teach them the education behind an informed decision. So that's like a huge green flag where I'm not pushing a decision. These are the things you should know and you make the decision, sort of a thing.
Well, and I feel like then it goes back to still like the collaborative process of it's ultimately up to the patient. Like you get to decide what you're going to do and what you're going to listen to and not listen to. But at the same time, you also now know what's all out there on the table. And if you think it's a reasonable idea, and if the doctor is on the same page as you, I mean, probably do it. Though I am curious one thing, because you mentioned LDL, and this has nothing to do with diabetes. This is just an LDL thing that I don't know, it's been on my mind for like 10 years. So you're familiar with the like particle size LDL test, right?
Yeah, the lipo little a, lipo little b.
Yes. So like I know a lot of people listening, I don't know if they realize like LDL most of the time is calculated, it's not actually measured.
Yes.
So the biggest thing that drives me nuts is, and I know in diabetes land we get this all the time because people will have an LDL to be like 121 and they'll be like statin. And then they're like, I don't want to do a statin. And I'm like, did they test for the particle size? Cause that's a whole separate thing. And then a lot of times like, I don't know what that is. So do you have a perspective, if you could simplify the particle size test, like what that means, just so people know? Cause I touch on it every now and then. I don't go into it nearly as much as I'd like to, cause I nerd out on things like this sometimes.
Yeah. I will say, admittedly, I'm not a huge expert on it. So one caveat, asterisk there. From what I know about it, so I think lipoprotein B or A has higher associated risk, especially if it's elevated for heart attack risk and stroke risk and atherosclerotic disease. So that's the first point. The second point is anything in kind of medicine is like, if we test for it, does it change our management, which is the big sort of thing, right? Outside of the realm of like, I just want an MRI to know what the hell's going on in my shoulder. That's one thing, but will getting an MRI change whether or not you go to physical therapy or you get it surgically, replaced? So apolipo A and B kind of fit in that same kind of realm. Like if you're someone that otherwise should be on a statin, you certainly like, you don't need to get the apolipo A or B. Like it's like, there are too many things that are like, this guy, regardless of like apolipo B is through the roof or not, like that doesn't change whether or not they need to be on a statin. So oftentimes I can see providers not getting it in that sense. Where I have seen it implemented, and I think the evidence base supports this, is kind of in that gray zone where going back to the ASCVD risk score of 7.5 to 20%, you have an intermediate risk of stroke and heart attack. And so someone who doesn't want to be on a kind of sits in, and if who doesn't want to be on a statin, sits in that kind of intermediate zone, you can get an apolipo A and an apolipo B because it gives you information like, holy crap, your apolipo B or A is like 200, right? And it's through the roof. You should consider now a statin. Or actually, that looks, it's pretty low. Your risk now is a little bit lower than I otherwise would have thought. I feel a little bit more, or I feel less concerned that you need to be on a statin. I feel a little bit more okay with that. Another test that kind of fits into that, I'm sure you've heard, is the CT calc score, where you'll get the CT calcium score of your coronary arteries. If someone doesn't want to be in a statin and is in that intermediate zone, you certainly can get this, and that will give you a little bit more information as to this person's high risk or this person's lower risk. So that's as much as I know about it. Yeah.
Well, and I always, with the particle size, I always describe to people as it's like a spectrum for LDL. Like there's one side where it's the, like you described, the small, dense atherosclerotic ones where it's going to clog everything up and be terrible. The other side, the fluffy, light, happy side, that's actually cardioprotective. And so it's like, if your LDL is elevated, but it's all the way over on the side where it's fluffy and happy, you might not need a statin versus the alternative. But what I also will caution people with that is the other factors have to still be in play. Like, are you active? Is your food on point? Are your blood sugars controlled? Like you have to go through the whole progression. If it's like, this is the one part that's the sticking point, then consider the test. But that's just something where you have the familiarity, and I figured it'd be fun to jam out on that a little bit because
it's a good one. And I think another thing, because it's on our boards, and I'm sitting for the FM boards in like April. I think a lot of the evidence on apolipo A, I don't know if it has changed since that question came out, is actually done on middle-aged Caucasian men. So the kind of heterogeneity of that evidence is kind of hard to now, showcase to your 40-year-old Asian female, right? Like it's
Right.
that sort of a thing. Yeah.
The representativeness, and I think that's something just to people to know for a lot of where the recommendations come from. Understand the study population should be, as you were describing, it should be more just, it should have a lot more diversity represented in it, because it can't just be, oh, cool, it's a bunch of, 40 to 60-year-old white dudes. Like, that's nice. The females doesn't represent any other ethnicity. Like, the risks in different groups are going to be different. So understand that. So that's why the larger population studies are needed and are important too.
Yeah. And study design is also important too. I think there's like a lot of studies that are just like, like Norwegian countries, and then that's it, or like Irish people, and then it comes out in JAMA or New England Journal and doesn't always apply to the standard average American.
Oh yeah. Or you'll get like a small subset in like one town, and it's like, that's cool. It's a Midwestern town in the middle of nowhere, which I grew up in the Midwest, so it's okay for me. But at the same time, right? Like it should be more representative if you want it to be actually like, okay, can be applied and generalized out to a lot of people. So fun random study tangent from my light PhD, then left the PhD days. But tell us, because I didn't get to chat about this with you, except for at the way beginning, the lifting side of things. Obviously, it's a big part of your life. And as a provider, it's a pretty rare thing. So if patients come to you and they express interest in, hey, I want to start working out, or I want to start lifting, I know I have my, insight on it. I'd be curious, on the doctor side, if it's any different, or what you would say to someone who comes to you. Let's say they have, type 2 or type 1 diabetes. They want to start working out, don't know where to start. How would you recommend that they start out?
That's a really good question. And I've since starting like residency 3 years ago, with as much knowledge as that I have in exercise and like enjoyment out of it, it's still like a work in progress, like, cause you get so many, you have to just individualize it. But at some point, like that's expecting a lot out of the provider who may not have the knowledge, right? It's like, how do I individualize the 40-year-old Asian versus a 50-year-old Caucasian male with different barriers, like work versus lifestyle versus comorbidities. So to like, I've been trying to like simplify the process, and I've had a few community preceptors kind of reach out and like, how, with that same question, right? Like from ground zero, how do I start with anyone? And I think that the process is like really simplified as much as you can, because I don't expect providers to have all this great in-depth knowledge about hypertrophy and programming and things like that. So I think starting off simple. So a lot of my patients, I have this kind of like, we have different clinics at our residency. So we have like psychiatry, weight management, MAT, psych, I already said psych, surgery clinic where we do small things. I created like this clinic called the fitness clinic, where it's in tangent with a weight management clinic, where I try to do weight management, but also like exercise. So that's the process that I've been trying to instill, the simplified process really. So I like to start the patients off on like a 3-day per week of some sort of exercise, 3-day per week, because I think it's more doable than 4 to 5. And I think it's a little bit more motivating / I got to actually do something than 1 to 2. So like 3 is that like sweet spot. Even for powerlifting clients of mine, like they're like, let's do 4 to 5. I'm like, now you've got a full-time job, you got kids, you're doing 3 days a week. Sorry. So 3 days a week, I think is a good point to start off of. And then a little bit of individualization is like, what do you like more? Do you like cardio or do you like resistance training? Knowing at the end of the day, both are important. I have a little bit more bias towards resistance training, but if the individualization comes from like, what are they going to stick more to first? Like, what is the consistency they're going to stick to? So if they like resistance training, or if they like cardiovascular exercise, implementing that 2 out of 3 days, and then the other 1 out of the 3 days is kind of where I start. For the resistance training, I have my go-to exercises, the ones that like, I just need dumbbells. They're pretty cheap. I show them in the office because I have my own dumbbells. They're a little bit better than resistance bands. Resistance bands can be like clunky. How do I set this up? How do I like cling it to like a door hinge, that sort of a thing. So my go-to exercises, and I encourage like all providers to find your own go-to exercises. Mine are, again, just to get them to do some sort of resistance training. So I do a goblet squat, some sort of like RDL hinged, and then some sort of floor press, and then some sort of overhead shoulder press. There is, I like to make it like more or less compound movement, not too difficult. And we're not doing like tricep overhead extensions or bicep curls like that are kind of boring. I do 4 sets of 10 to 12 reps. And then we build off of that, week to week, month to month. So that's their kind of starting off for resistance training. They don't have to go to the gym for this. They can do it at home. They certainly can go to the gym for this. You can do it with friends. It takes 30 minutes at most. It's difficult enough. And then the cardiovascular exercise, if they already know what they like to do, rather, like whether it's in the treadmill or they like to go on walks or walk their dog or whatever it is, I just kind of measure that objectively, right? So like, let's do, if you're going to walk your dog, you should be out there for 20 minutes or 30 minutes. And then we build off of that. So it doesn't change what they're already doing, but it makes it like, all right, this week I'm going to do the base. Next week, add 5 minutes. Next week, add another 5 minutes, right? If they don't know what they like to do for cardiovascular exercise, I oftentimes just do steps. So a step counter on their phone, like the health app or their watch. We start off 5,000 steps, 6,000 steps, 7,000 steps, that sort of a thing, but really have an objective metric to now the whole North Star idea where it's like, Are we getting closer to our North Star, our ultimate goal? So that's that's like the base. Everyone starts off there because it's simple and somewhat individualized, and then you build off of it. Yeah.
Well, and it's hilarious because I was curious your take on if and how different it was going to vary from mine. And ultimately, they're both very similar. Like if people have listened to earlier episodes of this, like I'll literally be like 3 times a week, 30 minutes, plenty. Try to get a mix of cardio and strength. Whatever you like more, do more. So it's very similar to the same approach that I've got. But I feel like the important part of it is, like you emphasize, it's doable and you don't have to go anywhere. Like you can do it at home. It's not going to take eternity for you to do. You can fit it into your life easily. You don't need a ton of equipment, but it's just getting you in motion. And then at that point, being able to say, hey, I'm going to continue building on this. And maybe, they actually start to fall in love with it. And then they start to do it more and you can get more intense. But I feel like just that beginning and opening that door and emphasizing, hey, this is a really big deal. Whether you have diabetes, whether you don't, it's just absolutely massive. But the blood sugar impacts of resistance training are so well documented, but also just insane. And so that's why I'm such a stickler of like, we've got to have something, because that muscle mass alone, I mean, the improvement in insulin sensitivity at baseline is just incredible. Then also every single time you do it, you're going to have that after effect of insulin sensitivity boost for at least 24 hours, if not longer. Like it's a no brainer, at least in my opinion. But
even more reason to start lifting weights. It's the way of the future.
Literally, I was going to say, I feel like I was late to the party, although at the same time, I feel like lifting's exploded more over the past like 20-ish years, which is kind of wild.
Yeah.
I was thinking about it too. I was like, I started lifting like 18 years ago. Like it's kind of insane for me to think about. I'm like, damn, I'm old.
Yeah. It's the people who like have always lifted, always continue to like lift. Did you play sports?
I did. I played baseball, volleyball, and round with track, cross country. I wish I played football, but I was too little. At the time, I would have done great with football if I had my current size, like in high school, but I didn't, unfortunately.
Yeah. I feel like the athletes are the ones that are easier to be like, this is the plan, this is what we're going to do. And like, they just know kind of what it takes.
Did you play sports?
Yeah. I played soccer competitively. I was really into basketball. I think basketball, I always loved basketball. That's the one like I always watched, but I was also just way too short for that. So I did soccer competitively throughout high school and then kind of dropped it in college. Yeah.
But I feel like to your point, like the athlete side, and just people shouldn't listen and be like, oh, I'm not an athlete, I'm never going to be able to train. Like you absolutely can train. Sometimes just the competitive side of people can come out, makes it easier to start. But it doesn't mean just because you didn't play any sports does not mean you can't start lifting and training and being active, because you absolutely 100% can.
Yeah, 1000%. There's a lot of like, I don't know what to call like stereotypes or myths when it comes to like lifting weights that I think should be really challenged in today's day and age. And like one of the things why I like exercise and like counseling patients on it so much is like people have their set idea of what lifting looks like, whether it's like a really jacked, juiced bodybuilder or someone who like lifts hundreds of pounds, like it doesn't have to be like that. You know what I mean? Like there are many reasons that are good outside of that like require resistance training. And I think to fight that bias that people have about resistance training will be interesting.
Well, and the bulkiness. Oh no, am I going to get bulky? Am I not going to be able to move well? Can I not like lift my arms over like all of these things? If you're willing to, pay attention and make sure you're doing it the right way. And no, you will probably not get bulky unless you eat and train to get bulky. And you have to do both of those. Very well. But no, I'm grateful we got the chat. I feel like I could totally go on and then we'd be here for another like hour. But where can people find you if they want to, talk with you more about the programming you do, or even potentially see you as a patient?
Yeah. So let me double check my Instagram handle. So it's Danny, DANY _Delifto, DELIFTO. So Danny _Delifto on Instagram. You can find me there. Shoot me a message. Happy to always chat with people.
Well, and I will link that in the show notes as well in case people want to be able to look there and maybe they don't catch it. But thank you so much for coming on the podcast. I'm grateful you were able to do it. And I'm obviously, for anybody listening, if you enjoyed this episode, definitely reach out. And also, if you're loving the podcast, definitely drop us a 5-star on Spotify, Apple, wherever you're listening. Mean the world to me and it'd be very much appreciated. But I will see all of you in the next episode.
Hope you're ready for the next episode. Hey.